What if you can silence the constant noise of hunger? Not through sheer discipline, not through another fad diet that collapses after 3 weeks, but through a single weekly injection that fundamentally changes the way your brain and body respond to food. What if the clinical data behind that injection showed patients losing not 5%, not 10%, but up to 21% of their total body weight? Results that no medication in the history of obesity treatment has ever come close to producing. And what if that same medication worked consistently, not just for some patients, not just for certain metabolic profiles, but for nearly everyone who used it correctly? That medication is real. It's called tirzepatide. You likely know it by its brand name, Mounjaro. In this video, we are going to cover everything. How it works at the biological level, what the clinical trials actually found, how it compares, drug by drug, number by number, to every weight loss medication that came before it. What the side effects really are, separated from the noise and the fear. Whether you need to take it indefinitely, how to stop it without gaining the weight back, and most importantly, why doctors across the country are calling this the single most significant development in obesity medicine in a generation. By the time this video ends, you will have a complete, honest, medically grounded understanding of Mounjaro. Not a sales pitch, not a scare piece, but the full picture. Let's get into it. The problem that Mounjaro was built to solve. Before we talk about the drug itself, we need to talk about the disease it treats, because obesity is still misunderstood in ways that matter. Obesity is not laziness. It is not a lack of willpower. It is not a personal failure that a better attitude could fix. It is a chronic, progressive, biologically complex disease driven by genetics, hormonal imbalances, environmental factors, psychological history, and metabolic adaptation. The human body is designed, at a fundamental level, to resist weight loss. When you reduce caloric intake, your metabolism slows down to compensate. When you lose fat mass, hunger hormones increase to drive you back toward your previous weight. The system fights you. This is why dieting in isolation has such a poor long-term success rate. It's not that people lack motivation, it's that they are fighting a biological system that is actively working against them. For decades, medicine recognized this problem, but had limited tools to address it pharmaceutically. The medications available were either modestly effective, poorly tolerated, or both. That is the context in which Mounjaro arrived. And that context is what makes its results so remarkable. What Mounjaro is, and what makes it fundamentally different. Mounjaro is a GIP and GLP-1 receptor agonist. Let's unpack that, because the science is actually not that complicated, and understanding it will help you appreciate why this medication performs so differently from its predecessors. GLP-1 stands for glucagon-like peptide 1. It is a hormone your gut naturally produces after you eat. Its job is to signal to your brain that food has been consumed, to stimulate insulin release, and to slow the movement of food through your digestive system. GLP-1 receptor agonists, medications that mimic and amplify this hormone, have been used in diabetes and weight management for about a decade. Saxenda and Wegovy are both GLP-1 receptor agonists. GIP stands for glucose-dependent insulinotropic peptide. It is a second gut hormone that plays a related but distinct role in metabolism, energy regulation, and fat storage. Before Mounjaro, no approved weight loss or diabetes medication had ever successfully targeted the GIP receptor alongside GLP-1. Mounjaro does both, simultaneously. And the two mechanisms don't just add together, they amplify each other. The synergy between GLP-1 and GIP receptor activation appears to produce a metabolic response that is categorically more powerful than either pathway alone. It's the difference between pulling one lever and pulling two, except when you pull both at once, the door opens 3 times as wide. That dual receptor engagement is not a minor technical distinction. It is the entire reason the results look the way they do. How Mounjaro works inside your body. 4 pathways. Understanding the mechanism matters because it explains not just the weight loss, but the experience patients describe. Here is what Mounjaro does at the physiological level. The first pathway is appetite suppression. Mounjaro works directly on the hunger and satiety centers in the brain. Patients don't describe this as trying to eat less. They describe it as simply not thinking about food. The relentless mental background noise of appetite, the cravings between meals, the pull toward the refrigerator at night, the preoccupation with the next meal, goes quiet. For people who have spent years battling that noise, this shift is profound. It doesn't feel like deprivation, it feels like relief. The second pathway is delayed gastric emptying. When you eat a meal while on Mounjaro, that food stays in your stomach significantly longer than it normally would. The mechanical sensation of fullness persists well beyond the meal itself. You take a few bites and you are already full. You don't experience the rapid return of hunger that normally follows a meal. The stomach is still occupied, still sending fullness signals, long after a normal stomach would have emptied and triggered hunger again. The third pathway is early satiety. Even before physical fullness from volume occurs, Mounjaro triggers the brain's satiety signals. The body concludes the meal is complete well before the plate is empty. Patients routinely report pushing food away, not because they are forcing themselves to, but because they genuinely don't want any more. This is not willpower, it is biochemistry. The fourth pathway is metabolic enhancement. This is still being studied, but growing evidence suggests tirzepatide works at the cellular level to increase the rate at which the body burns fat for energy. Unlike some older weight loss medications that cause the body to shed muscle alongside fat, Mounjaro appears to preferentially target fat mass. This matters because muscle mass is your metabolic engine. Protecting it during weight loss means the weight stays off more durably. These four pathways, working simultaneously, create an environment inside the body where significant, sustained weight loss becomes not just possible, but almost inevitable, provided the patient is also making consistent lifestyle changes alongside the medication. The clinical data, what the numbers actually show. Let's talk about the science, because this medication's reputation is built on evidence, not anecdote. The landmark trial is called SURMOUNT-1. It was published in the New England Journal of Medicine and enrolled over 2,500 participants who were overweight or obese. Every participant followed the same lifestyle protocol, a structured diet and regular exercise. The only variable was whether they received a placebo or one of 3 doses of tirzepatide, 5 milligrams, 10 milligrams, or 15 milligrams. The trial ran for 72 weeks. Here are the results. The placebo group, making real lifestyle changes, eating better, exercising regularly, lost approximately 3% of their body weight. This is actually consistent with what well-conducted lifestyle intervention studies typically produce. 3% is what you get from sustained discipline without pharmaceutical support. At 5 milligrams of tirzepatide, patients lost an average of 15% of their body weight. At 10 milligrams, the average loss was 20%. At 15 milligrams, results plateaued at approximately 21%. But that plateau is at a level no other non-surgical intervention has ever reached. To translate those numbers into something tangible, a person starting at 220 pounds who reaches the full therapeutic dose of Mounjaro could expect to lose between 44 and 46 pounds. Not through gastric bypass, not through a medically supervised starvation protocol, through a weekly injection combined with consistent lifestyle habits. Now let's put those numbers in historical context, because the comparison to previous medications is where the magnitude of this breakthrough becomes clear. Phentermine, one of the most prescribed oral weight loss medications for decades, produces approximately 5% weight loss at best. It works primarily by stimulating the central nervous system to suppress appetite and increase metabolic rate. It has significant limitations: cardiovascular concerns, tolerance development, and a very modest ceiling on its effectiveness. Saxenda, which entered the market in 2014 as the first once-daily injectable GLP-1 agonist specifically approved for weight loss, produced 8 to 12% weight loss in clinical trials. That was a genuine step forward at the time. It was better than anything oral, but it required daily injections, and its ceiling was still well below what patients with significant obesity needed. Wegovy, semaglutide, the medication that generated enormous media attention starting around 2021, achieved approximately 15% weight loss with a once-weekly injection. When Wegovy arrived, it felt like a revolution. 15% was more than anything that had come before. Doctors and patients were genuinely excited. And it was, and remains, an excellent medication. But Mounjaro produces 20 to 21%, consistently, across almost every patient profile. That gap, from 15% to 20%, may sound modest in percentage terms. But in absolute terms, for a person at 250 pounds, the difference between 15% and 20% weight loss is 12.5 pounds. It is the difference between meaningful improvement and genuinely life-changing transformation. And the consistency with which Mounjaro achieves it, across different ages, different starting weights, different metabolic histories, is what truly sets it apart. Side effects. What's real and what's overblown? No medication earns credibility by minimizing side effects. So let's address them directly and completely. The most common side effects of Mounjaro are gastrointestinal, nausea, occasional loose stools or diarrhea, and constipation. These are real. They affect a meaningful portion of patients, particularly during the early weeks of treatment or following a dose increase. They are also, in most cases, manageable and temporary. The key to minimizing GI side effects is the titration protocol. Mounjaro is available in increments of 2.5 milligrams, and the standard approach is to begin at 2.5 milligrams and increase the dose by 2.5 milligrams no more frequently than every 4 weeks. This slow, measured escalation gives the digestive system time to adjust to each new dose level before moving to the next. Patients who follow this protocol carefully experience significantly fewer and milder GI symptoms than those who escalate too quickly. For most people, any nausea that does occur is mild, predictable, often appearing in the first day or two after an injection, and resolves as the body adapts. Within a few weeks at each dose level, the discomfort typically disappears entirely. Less common side effects include mild elevations in resting heart rate, fatigue, and occasional musculoskeletal discomfort. These have been reported in clinical trials and in real-world use, but their occurrence is relatively infrequent, and in the vast majority of cases, they resolve on their own without requiring any change in treatment. The side effect that consistently attracts the most concern, largely due to the warning label on the medication, is thyroid cancer. This requires a careful, honest answer. The warning exists because studies in rodents found that high doses of GLP-1 receptor agonists over extended periods produce thyroid C-cell tumors in rats and mice. That finding was real, and it appropriately triggered regulatory caution. However, and this is important, the SURMOUNT clinical trials, which together enrolled thousands of human patients over extended follow-up periods, found no association between tirzepatide and thyroid cancer in humans. The cellular mechanisms that cause tumor development in rodents do not appear to operate the same way in human thyroid tissue. The current medical consensus is that the rodent finding does not translate to a meaningful risk in humans. That said, anyone with a personal or family history of medullary thyroid carcinoma or multiple endocrine neoplasia syndrome should discuss this specifically with their physician before starting the medication. Do you have to take Mounjaro forever? This is, without question, the most common question patients have, and it deserves an honest, nuanced answer rather than a reflexive reassurance. For patients managing type 2 diabetes, the medication may need to be continued long-term, potentially indefinitely, unless the diabetes goes into remission through weight loss and sustained lifestyle change. That is not unique to Mounjaro. That is the nature of chronic disease management. For weight loss, the situation is more flexible and more encouraging than many people expect. The important thing to understand is that Mounjaro does not simply suppress weight while you are taking it and release it the moment you stop. The medication produces real physiological changes. Changes in how quickly you feel full, changes in stomach capacity over time, changes in appetite set points that persist beyond the treatment period for many patients. Clinically, a significant number of patients who discontinue Mounjaro after reaching their target weight continue to maintain that weight. Some continue to lose modest additional weight in the months that follow. This happens for two reasons. First, The stomach's physical capacity appears to adapt over months of reduced food intake. Stretch receptors recalibrate. The stomach's functional volume decreases. Patients find that even after stopping the medication, they still reach fullness faster than they did before treatment began. The body has been remodeled to some extent by the months of reduced food intake. Second, and equally important, the lifestyle habits built during treatment persist. Mounjaro gives patients a sustained window, often 6 months to a year or more, during which making dietary and behavioral changes is dramatically easier than it would normally be. Hunger is no longer an obstacle. The desire to overeat is gone. Patients who use that window wisely to genuinely restructure how they eat and how they move carry those habits forward even when the medication is no longer present to suppress appetite. When discontinuing Mounjaro, the approach should mirror how treatment was started, gradually. A slow, stepwise taper, reducing the dose incrementally over several weeks rather than stopping abruptly, has been shown to significantly reduce the risk of rebound weight gain. Just as the body was introduced to the medication slowly to allow adaptation, it is given time to adjust to its absence. Done correctly, this approach makes the transition off the medication much smoother and more durable. The evolution of weight loss medicine, from phentermine to Mounjaro. To understand why Mounjaro represents a true turning point, it helps to trace the arc of how obesity medicine has evolved. For most of the second half of the 20th century, the dominant pharmaceutical approach to weight loss involved sympathomimetic agents, stimulants that increase metabolic rate and suppress appetite through the central nervous system. Phentermine became the most widely used. It was effective for some patients, modestly so, and it remains in use today. But its ceiling was always low, 5 to 8% weight loss, and its cardiovascular effects limited long-term use in many patients. The major paradigm shift came in 2014 with the approval of liraglutide as an injectable weight loss treatment. This was the first time a GLP-1 receptor agonist was specifically approved for obesity, and it produced meaningfully better results than phentermine, 10 to 12% weight loss with a daily injection. It worked differently, more safely for most patients, and without the cardiovascular concerns of stimulant-based approaches. It was an important milestone. Then, semaglutide arrived in 2021. Ozempic had already established semaglutide's profile as a powerful diabetes medication. When the same compound was reformulated at higher doses as Wegovy for weight management, the results were startling enough to generate mainstream media coverage on a scale rarely seen for pharmaceutical developments. 15% average weight loss, once weekly, with a safety profile that was generally well tolerated. For many in the medical community, it felt like the ceiling had finally been found. It hadn't. Mounjaro entered with data showing 20 to 21% weight loss, and it did so with an additional quality that may matter more than the numbers alone: consistency. Wegovy worked well for most patients, but there was a real non-response population. Patients who followed the protocol, received the injections, made the lifestyle changes, and simply didn't see meaningful results. That non-response rate was frustrating and clinically significant. With Mounjaro, that pattern has largely disappeared. Nearly every patient who uses the medication correctly and consistently loses a significant amount of weight. The consistency of response across different patients is one of the most important and clinically meaningful aspects of what makes this medication different. Lifestyle, the non-negotiable foundation. There is one thing that needs to be said plainly, because no amount of enthusiasm about a medication should obscure it. Mounjaro is a tool, a powerful one, but it works best, and its results last longest, when it is paired with genuine, sustained lifestyle change. The medication makes eating less dramatically easier. It removes the biological obstacle of hunger. But the habits built during treatment are what determine whether the results last years or whether weight gradually returns after stopping. What does that mean in practice? It means prioritizing whole foods over processed ones. It means eating at regular intervals in reasonable portions, 2 or 3 balanced meals per day rather than constant grazing. It means getting consistent physical activity, not as punishment, but as a long-term investment in metabolic health and muscle preservation. And it means treating the period of treatment as a genuine opportunity to restructure the relationship with food, one that the medication makes unusually accessible. Patients who approach Mounjaro this way, as a tool that creates the conditions for lasting change rather than a substitute for it, consistently achieve better long-term outcomes than those who rely on the medication alone. The drug quiets the noise. The lifestyle change builds the foundation. Why this moment matters. Obesity affects hundreds of millions of people globally. It is one of the leading drivers of type 2 diabetes, cardiovascular disease, joint disease, sleep apnea, and certain cancers. It reduces quality of life and shortens lives. And for generations, the medical community was unable to offer the people it affects a reliably effective pharmaceutical solution. Mounjaro does not solve all of that alone, but it represents the clearest evidence yet that obesity can be treated medically, not managed minimally, not addressed cosmetically, but genuinely treated, with results that are durable, meaningful, and transformative for real patients. If you've been struggling with your weight, whether the goal is modest or significant, this medication warrants a serious, open conversation with a qualified physician. Not because it is appropriate for everyone, not because it removes the need for lifestyle change, but because the evidence behind it is real, the results are documented, and for many people, it may represent the first time that a genuinely effective option has existed. That conversation is worth having. And for many patients, it is one that changes everything. Medical disclaimer. Tirzepatide, Mounjaro, is currently FDA approved for the treatment of type 2 diabetes. Its status for weight loss approval may have changed since this script was written. All treatment decisions should be made in consultation with a qualified, licensed healthcare provider who can evaluate your individual health history and needs.